more I'm trying कि आप लोगों का time waste ना हो, more it is getting wasted. So don't worry, we have just wasted 10 minutes. Now we will just be on time. Okay, अभी ठीक है ना? Voice is clear everyone? Please give me a thumbs up if the voice is clear. Okay, good. Starting with physiological changes, 2 hours may we have to read a lot, so we'll be revising whatever we have read. If there is any controversial point, please feel free to message. Physiological changes. Question number 1. A 34-week pregnant woman feels dizzy when she lies down. She feels better when she stand up. What it is? Very obvious. Supine hypotension syndrome. So when somebody is feeling hypotensive on lying down, that is supine hypotension syndrome due to compression of IVC. What important points you have to remember here? See, it is a third trimester sign. Supine hypotension is due to compression of IVC. Point number 1. It doesn't come in early pregnancy. It is a sign that comes after 28 weeks. Uterus should be heavy enough to compress IVC. What is happening? The cardiac output is decreasing. So cardiac output is decreasing because of compression. What will she do? She will lie in left lateral. On changing to left lateral position, cardiac output rise. How much? 20%. 20% cardiac output rise, and that is why she feels better. ठीक है? चलो. What is abnormal heart sound during pregnancy? So yes, pregnancy में lot of heart sounds develop. Can you please answer this question? Write down here. I'll write down what are the normal heart changes that happen. Normal heart sound changes that happen. Please mark the answer. Abnormal. Which one of these is abnormal? S1, S2 split and loud. That is normal. Why? Because itna sara there is a lot of blood coming to the heart. What left side? So a lot of left lateral side. Why? Because when it is lying left lateral side, your inferior vena cava is on right side, and when women lies on left side, the uterus shift towards right. It falls towards the left side, and IVC being a right sided structure, it relieves of its pressure. That is why left lateral side. Correct. Diastolic murmur is abnormal. It is never normal in pregnancy. What is normal is S1 is loud and S1 is split. So you can see, not S2, sorry. So you can see split S1. It is clearly split and it is loud because lot of blood is pouring into the heart. Next one thing happen is ejection systolic murmur. Ejection systolic murmur. Why ejection systolic murmur happen? Dekho, whenever blood is ejecting whenever heart is ejecting a lot of blood out, whenever a lot of blood is being ejected forcefully, ejection systolic murmur will always happen. Like in anemia. Anemia mein heart tries to push lot of blood, try to supply lot of blood to brain. So anemia may be ejection systolic murmur is normal. Similarly in pregnancy, ejection systolic murmur is normal because of lot of blood being there. What else is normal? S3 sound. S3 is a ventricular gallop sound. So because of, again, when the ventricle is dilated, there is a gallop sound heard because of lot of blood pouring into it. So S3 gallop is normal. What is not normal? Any diastolic murmur is not normal, and S4, they are not normal. Okay? Sometimes a continuous murmur can be heard. A continuous murmur. What is that continuous murmur that is heard? That is mammary shuffle. Increase in blood flow to the mammary glands. That is looking like that sound is like whoosh, 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 like this. This is a continuous murmur, that is mammary shuffle. Okay? So here what is abnormal heart sound? Diastolic murmur is abnormal. Okay. What changes happen in cardiovascular system in pregnancy? The blood volume rise. So there is a significant rise in blood volume, and there are two things that are happening. Blood volume is rising and BP is falling. So blood volume rise, BP fall, as a result cardiac output is increased. Cardiac output increase is maximum at around 28 weeks. 45% increase in cardiac output. Now next cardiac output increase further when there is second stage of labor. With every push, cardiac output is more. And maximum cardiac output is when she has immediately delivered. So as soon as she has immediately delivered, she has pushed the baby out. Now there is no pressure on IVC, cardiac output further rise. So the maximum chances of heart failure are in which stages of pregnancy? It's in immediate postpartum. That is the maximum chance of heart failure that happen. Next, when does cardiac output return to pre-labor value? Labor में बढ़ गया था ना, so pre-labor value it returns 2 hours after delivery. 2 hours after delivery it returns to this pre-labor value. And when does it return to pre-pregnant value? Like a normal person, when does it return to a pre-pregnant value? After 2 weeks. Okay? That's when it returns. Okay? Why are you leaving? What happened? Okay, कोई बात नहीं, that's okay. If there is a problem, please let me know. That can be solved. And if it cannot be solved, right. What happened in renal system? Let's quickly revise. Renal system में क्या होता है? Again, there is lot of blood pouring into the renal system also. So as a result, renal plasma flow is increased. Glomerular filtration rate is increased. ठीक है? As a result, women will produce more urine. But since the blood is now more dilute, there is a lot of blood in her system, it is very dilute, serum creatinine and serum urea concentration fall. Remember, you have to remember all this. Question has been asked on this, it will be asked again. So serum creatinine, serum urea concentration fall because of lot of water that is being collected in the maternal system. What else happened? Women suddenly start secreting protein. So protein urea and glucose urea are normal in pregnancy. It happens. Anything more than 300 milligram in 24 hours will be abnormal, but normal lesser than that protein urea does happen. Yes, we are discussing 5-year MCQs, correct. So protein urea and glucose urea does happen, that is normal in pregnancy, but it should not go beyond 300 milligram in 24 hours. ठीक है? What changes happen in respiratory system? Respiratory system में क्या हो रहा है? Diaphragm is it. So first we will read a little theory and then we will see how whether we are able to do the questions or not. ठीक है? So read a little theory and then let's solve questions together. What happened in respiratory systems? Respiratory system में diaphragm is elevated. When diaphragm is elevated, what will happen? Certain values will reduce. What is reduced? Diaphragm is elevated. What will be reduced? Residual volume reduced. Expiratory reserve volume reduced. What will stay normal? What will not change? Since diaphragm is elevated but rib cage expands horizontally, total lung capacity normal, vital capacity normal. What is increased? There is one thing that is increased. Tidal volume. Tidal volume. So each breath that is, the air that is taken in each breath, that is increased. So women takes deep breaths. So tidal volume is increased. What about respiratory rate? Can somebody tell me what about respiratory rate? Respiratory rate stays normal. Remember, respiratory rate doesn't change. Okay? She is not tachypnic. She is taking deep breaths. So tidal volume is increased. Rest all decrease. Okay? What about change in coagulation? We know already that pregnancy is a hypercoagulable state, isn't it? So obviously coagulation factors will rise. All coagulation factors rise, remember, except 11 and 13. Except 11 and 13, all good. So except 11 and 13, all coagulation factors rise. Okay? Antithrombotic agents like antithrombin 3 fall. Protein S fall. Protein C doesn't fall, but body develop resistance to protein C. What about platelets? Platelets fall. There is thrombocytopenia, but that has been asked in question. Dilutional thrombocytopenia. Dilutional means blood is so much, water is so much that now concentration has fallen. So dilutional thrombocytopenia happen up till 1 lakh, not below that. So up till 1 lakh. Okay? Okay? So this was all about the physiological changes in pregnancy. Question have been asked on dilutional thrombocytopenia and question have been asked on heart sounds and heart changes. Okay? Coming to basic obstetrics. Now, which hormone regulates folliculogenesis in early stage? Please tell me the answer fast. Which hormone regulates the folliculogenesis in early stage? Please answer fast. Correct. FSH. So his name is follicle stimulating hormone. Okay? So we will first read all the important points because see, it's very difficult to complete whole obs and gynae in 2 hours. Okay? So what our concept is, we will revise every point related to each topic and then we'll do the questions. So meiosis 1 completes at what stage? When does meiosis 1 complete? Meiosis 1 completes just before ovulation. So just before ovulation, meiosis 1 completes. And what is released? What is released is secondary oocyte and the first polar body. They are released. Okay? When does meiosis 2 completes? So when meiosis 1 completes, secondary oocyte is in metaphase. It is arrested in metaphase of meiosis 2. And when does this gets complete? Just before fertilization. So just before fertilization, meiosis 2 completes, and what we get is a female pronucleus. Okay. So 1.5 hour will be for ops. So you are right कि ops में ज़्यादा important है. Let's more focus on ops. Gynae में what I am planning is last के 20 minutes में we will just do important points. ठीक है? We'll just brush up the important points. Okay. Meiosis 2 completes just before fertilization, and what we get is a female pronucleus and your second polar body. So when is first polar body released? Just before ovulation. When is second polar body released? Just before fertilization. ठीक है? Hormone responsible for early folliculogenesis. Hormone responsible for ovulation. Can someone tell me the hormone responsible for LH surge? I have told this in many times in my class. Why LH surge happened? Abhi tak LH was normal. Why suddenly it surges? What is the hormone responsible for LH surge? Why? What is the reason for LH surge? More than 200 picograms of what? Of for 48 hours what? Which hormone you are talking about? Which hormone? You are absolutely right. There is a hormone which is persistently high for 48 hours. Perfect. That result in LH surge, estradiol. So the hormone responsible for LH surge is estradiol. Estradiol is persistently high for 48 hours. That result in LH surge. Okay? Where does fertilization happen? Fertilization happen at the ampulla part of the tube. Right? When fertilization has happened, it travels in the tube for 3 days. After 3 days, the embryo comes into the uterus. And when does implantation start? So implantation happens at the upper posterior part of the uterus. That is the site for implantation. But when does it start? It starts at day 6 to day 7 post fertilization. Day 6 to day 7 पे implantation start and it is completed by day 9. By day 10, it is completely inside the endometrial wall. So day 6 पे, day 7 पे it starts and it is complete by day 10. ठीक है? So there is something called as in basic obstetrics, there is something called as acrosome reaction. What is acrosome reaction? When the sperm is near the ovum, then acrosome, which is formed, acrosome part, which is basically derived from the Golgi apparatus. So that contains a lot of enzymes. Main enzyme of this acrosomal part is hyaluronidase and acrosin. These are the two enzymes that are released as soon as the sperm is very near to the ovum. So if question is asked, can somebody tell me where does acrosome reaction take place? Where does acrosome reaction take place? At what site the acrosome reaction will happen? What is that part of genital tract where the acrosome reaction will happen? Acrosome reaction is when the sperm is very near to the ovum surface and suddenly it fuses with this acrosomal membrane and releases the enzymes. Where does it happen? In fallopian tube. So acrosomal reaction happens in fallopian tube and the purpose is to pierce the zona pellucida. That is the purpose. What is the purpose? To pierce the zona pellucida. So reason for acrosome reaction is to pierce the zona pellucida. Correct. Happening in the ampulla part of the tube. Okay? Another reaction is cortical reaction. What is cortical reaction? As soon as the sperm is inside the ovum, a lot of calcium granules are released and they cover the ovum. What is the purpose for cortical reaction? Who can tell me? What is the purpose of cortical reaction? Fast. Why? Why it releases calcium granules? Why they go and cover the ovum surface? What is the purpose? To prevent what? What am I trying to prevent? Polyspermy. Once one sperm has entered, I don't want another sperm to enter, and that is the reason for cortical reaction. Cortical reaction makes ovum impermeable for any more sperm. So what I am preventing is polyspermy. The reason for acrosome reaction is piercing the zona pellucida. The reason for cortical reaction is preventing polyspermy. Okay? Correct. So remember what is the purpose of each step. Now see, in oogenesis, after ovulation, the ovum will be, once the ovulation has happened, what ovum are we getting? Good. What ovum are we getting after? We are getting a secondary oocyte. Just after ovulation, we are getting a secondary oocyte who is arrested in metaphase of meiosis 2. So that's what we are getting, secondary oocyte in M2. Polyspermy is prevented by which action? Cortical reaction. Okay? Decreased membrane potential is not for prevention of polyspermy in mammals. It happens, but in non-mammalian organisms. Embryo implantation takes place at which day? So embryo implantation starts typically at day 6 and 7. Okay? So that covers the basics of the obstetrics. Now we come to the placenta formation. Okay? So when the placenta forms, placenta is formed by contribution of two parts, maternal and fetal. Again a previous year question. Maternal part is called as decidua, remember, basilis. Decidua basilis is that part of mother that participates in placenta formation. Decidua basilis. What about the fetus? The fetus part that participates is the chorion frondosum. These two together contribute for placenta. The maternal contribution is 1/3 and the fetal contribution is 2/3. Okay? When does fetoplacental circulation is established? Before going for fetal-placental circulation, what fetoplacental circulation? Fetus completely invades inside the maternal endometrium. It goes totally inside maternal endometrium. It invades the maternal vessels. So these thin vessels are turned into big channels, so that a lot of blood can be given to placenta. So which vessels are invaded? Spiral arterioles. Spiral arterioles are invaded by whom? By endovascular trophoblasts. So remember these two terms. Spiral arterioles are invaded, and who is invading them? Maternal endovascular trophoblasts are invading these arterioles, converting them into big wide channels. Okay? Now when the invasion happens, the fetoplacental circulation is established. When is fetoplacental circulation established? Sorry. That's the older one. Day 17 post-fertilization. Day 17 post-fertilization, fetoplacental circulation is completely established. Okay? Now, more about placenta. So, when placenta is formed, another very important function besides nutrition for placenta is progesterone secretion. So, what place the progesterone is secreted? What is the site for progesterone secretion in placenta? Syncytiotrophoblast. Syncytiotrophoblast is the structure that secretes basically progesterones. Okay? Before the placenta takes over that function of progesterone secretion, who is doing the progesterone secretion? Who is doing this major function? Corpus luteum. So initially the progesterone is secreted by corpus luteum, which is later taken up by placenta. So corpus luteum से luteoplacental shift, this shift from luteum to placenta, luteoplacental shift, that happens at around 8 weeks to 10 weeks of fertilization. So 8 to 10 weeks post fertilization is the time when luteoplacental shift happen. Okay? How do we describe human placenta? Human placenta is described as it is discoid. Again a previous year question. It is disc shaped. It is discoid. It is hemochorial. Means heme of mother is coming in contact with the chorion of the baby. So it is discoid, it is hemochorial, and eventually it sheds. So it is deciduate. So these are the three terms by which we describe the placenta. hemochorial, discoid and deciduate. ठीक है. What are the steps of placenta formation? Implantation, that we have read, that starts at day 6 post fertilization. Cleavage, फिर decidua development, that is the third step where the decidua prepare itself for upcoming embryo, and the last step, the most important, is trophoblast development. These are the 4 steps of placenta development, right? What are the functions of HCG? HCG is human chorionic gonadotropin secreted from syncytial trophoblast. Syncytial trophoblast in placenta secretes HCG, and HCG ka, what is the major function of HCG? Again a previous year question. What are the functions of HCG? First, it saves corpus luteum. It saves corpus luteum till placenta takes over. So first function, it saves corpus luteum. Second, it stimulates maternal thyroid hormone. That is why in pregnancies where HCG is very high, mother develops hyperthyroidism. Function 2. Most important, function 3. HCG is the one that stimulates Leydig cells. In a boy baby, correct, it stimulates Leydig cells. What does Leydig cells secrete? Leydig cells secrete testosterone. They secrete testosterone that is needed for male genitalia formation. So male does not have LH when male is inside. So HCG stimulate Leydig cells for testosterone secretion for formation of male genitalia. The hormone that you are detecting in your UPT kits is HCG. Okay? During embryological development, testis would release testosterone. Which among the following is responsible for releasing testosterone? LH from mother, GnRH from fetal hypothalamus, or corpus luteum? HCG. HCG from the placenta is the one that is responsible for secreting testosterone. Okay? Now, a little bit about Liker. So Liker is again formed by contribution of mother and fetus both. Liker ki normal value is measured in AFI or single deepest pocket. Now there can be condition when Liker is extremely less. When do we define Liker is less? When the single deepest pocket is less than 2 cm. Okay? Yes, correct. Good. And tell me the AFI. How much should be the AFI to call it oligohydramnios? How much should be the AFI to call it oligohydramnios? Less than 5 cm. Single deepest pocket more than 8 cm is polyhydramnios, and AFI more than 25 cm is polyhydramnios. Remember, Liker is measured in centimeters. Okay? Let me clearly see all of your charts. So this is the definition of oligo and polyhydramnios. How will it present? How the question will give you oligohydramnios? The fundal height is lesser than the gestational age, and the uterus is filled with baby. Uterus is filled with baby. You can easily feel the fetal parts. Fetal parts are easily felt. Uterus is filled with baby. What about polyhydramnios? How the question will write polyhydramnios? Fundal height is more than gestational age. Okay? Fetal parts are not palpable. They are not palpable. Uterus is relaxed and fetal parts are not palpable. And fetal heart rate is less audible. Why? Because there is so much fluid. That is why it is less audible. Most important, what are the causes? What is the source of Liker? The source of Liker basically is fetal kidneys. That is the major source of Liker. So what are the causes? Whenever there is a kidney problem. Okay? So whenever there is single kidney, or baby is producing the urine but the urine is not coming out, like posterior urethral valves. Okay? Bladder outlet obstruction. What else can cause oligohydramnios? If there is preterm pre-labor rupture of membrane, PROM. So when there is PROM, again there will be oligohydramnios. Some kind of IUGR, some kind of placental insufficiency. Okay? All that will lead to oligohydramnios. Less urine, less Liker. What will result in polyhydramnios? More urine is being produced. More urine will be produced in conditions like mother has diabetes. Okay? What have you written? I'm not able to read that. So mother has diabetes, the baby will produce more urine. What else? So how the liquor is absorbed? Liquor is absorbed by the baby basically absorbs the liquor. So whenever there is problem of GI tract like tracheoesophageal fistula or esophageal atresia, that will result in more liquor because baby is not able to absorb it. Remember, very important, neural tube defects. Whenever there is neural tube defects, neural tubes are lying naked in the uterine cavity, they will keep on leaking the fluid. So neural tube defect. So whenever there is GI problem, will cause polyhydramnios. Whenever there is renal problem, that will result in oligohydramnios. Okay? Let's do the question. A woman gravida 2 para 1 present at 28th week, her uterus, can you see, fundal height is reduced and ultrasound mein absent liquor. Which of the following would be the most likely cause? What do you think it is the most likely cause resulting in reduced liquor, such a reduced liquor? Fetal renal anomalies. Okay? A patient 32 weeks pregnant present with over distended abdomen but not tense. It is not tense. Fetal parts are not easily felt. FHR is not easily audible. What it is? Can it be abruption? Abruption mein it is always tense. Always tense. So it is polyhydramnios. Okay? Which surface of placenta is this? So I have told you placenta is made from two contributions. One is the maternal contribution, another is the fetal contribution. So obviously there are two surfaces. One which is shiny and smooth and obviously where cord is attached. Where the cord is attached, obviously this part is the fetal part. Cord is coming from the baby. So this part where cord is attached is fetal part. And this part which is dirty, cotyledon like part where the cord is not attached, correct, that is the maternal surface. So this is a fetal surface. Okay? So that was all about basic placenta and basic obstetrics. Now we're coming to the diagnosis of pregnancy. So pregnancy can be diagnosed based on certain signs, symptoms, blood test and ultrasonography. Coming to signs, symptoms. You can divide signs, symptoms into presumptive, probable and positive. Okay? What are presumptive? If asked what are the presumptive signs? Remember, whatever signs are being felt by the patient herself. Whatever. Presumptive means she is presuming she is pregnant. So whatever signs are felt by the patient herself, that are presumptive. Like patient tells you that I am feeling the baby movement. Patient tells you I am having nausea. I am having increased urinary frequency. That all patient is telling you. So that is presumptive. Patient did the urine pregnancy test. That is presumptive. Okay, so everything that patient is having, you can't see. That is presumptive. Probable are those signs that you are judging them, that you are testing on the patient. Those are the probable signs. Okay, that is a way of remembering presumptive, probable and positive sign. Probable signs are vomiting. You tell me nausea, vomiting. Nausea, vomiting is a presumptive sign that patient is having them. Whatever you are feeling ballotment. आप करते हो ना ballotment, you ballot the baby. So ballotment, all the pelvic signs that we will read next. Blood pregnancy test that you are doing. All that is probable sign. So positive blood pregnancy test, ballotment and all the pelvic signs, the pelvic changes that you see, Chadwick sign, Goodell sign, they all are probable signs. Positive confirmatory signs are only 3. You see, you feel, you listen. कैसे याद करेंगे? You can feel the fetal parts, sign 1. You can auscultate the fetal heart, sign 2. You can see the fetus in the ultrasound, sign 3. ठीक है? So, what have you written? TVS and ultrasound blood test, UPT kit test. So, they are different. UPT kit test is a presumptive sign. Blood HCG is a probable sign. Ultrasound is a confirmed sign. Okay? So, confirmed sign are 3. Remember, see, feel and listen. So, see the ultrasound, baby is visible, sign, confirmatory sign. Auscultate the fetal heart, confirmatory sign. You can feel the fetal parts, confirmatory sign. So, we have only 3 confirmatory signs. Okay? Pelvic changes, which are the probable signs of pregnancy. Let's see the pelvic changes. What is this? So as soon as woman becomes pregnant, the blood flow to the cervix increase, resulting in a bluish tinge of cervix and vulva both. So cervix and vulva turn into bluish tinge, mainly vulva, and we call it Chadwick sign. Bluish tinge of the vulva and cervix, mainly vulva. Also, cervix becomes really soft. Goodell sign. Remember, good cervix is soft cervix. It is the earliest sign. It is the earliest sign that comes in pregnancy. It comes as early as 6 weeks. So it is the earliest pelvic change that comes in pregnancy. Goodell sign. ठीक है, तो pelvic signs basically 6 होते हैं. 3 are cervical, 3 are uterine. Cervical में आया Chadwick sign और जैकमेयर साइन, गुडेल साइन, और तीसरा आया ओसिएंडर साइन. व्हाट इज ओसिएंडर साइन? सो कैसे याद रखते हैं? दैट ऑल्सो हैव टोल्ड मेनी टाइम्स इन माई क्लास दैट व्हेन यू आर ट्राइंग टू कीप योर फिंगर अराउंड द ऑस से याद रखते हैं. व्हेन आई एम ट्राइंग टू कीप माई फिंगर अराउंड द ऑस, इट मीन्स इन द फॉर्निक्स आई कैन फील द पल्सेशन ऑफ एन आर्टरी. That is Osiander sign. On keeping my hand in the fornix, I can feel pulsation of uterine artery. That is Osiander sign. Os से याद रखना है. I'm keeping my finger on the os, near the os, and I can feel the pulsations. Osiander sign. So 3 cervical signs, 3 uterine signs. Can you see this one? One hand is in the vagina, one hand coming from abdomen, trying to approximate each other. This I have given multiple times. H, like letter H. One hand is here, one hand is in the vagina, trying to approximate in between. They can't approximate above and below. Why they can't approximate above and below? Because above is the baby, below is the cervix. So there is only softening in the middle segment, like letter H. Hagar sign. So whenever you see this image where hands are trying to approximate, that is Hagar sign. This one, here also bimanual examination, but it is not trying to approximate each other. You are trying to hold the cervix in between, like this. Like you are trying to hold the cervix, uterus in your palm. And when you are doing that, you can feel the uterine pulsations. Palmer sign. On bimanual examination, I can feel the uterine pulsations. That is Palmer sign. Last is the lateral implantation of the uterus of the baby leads to lateral growth of the uterus. This is Piscacchi sign. So 3 cervical signs, 3 uterine signs. All these, which of these is earliest to come? Goodell sign. That is a soft cervix is the earliest sign. Now come to some of the ultrasound changes in pregnancy. The first thing that is visible, first thing of pregnancy that is visible in ultrasound is G-sac. G-sac is seen at around 5 weeks. But remember, G-sac is not a sign of intrauterine pregnancy, though it is the first thing that is seen. It is not a sign of intrauterine pregnancy. There is something called as pseudo G-sac also, which is seen in, pseudo G-sac is seen in which condition? Who will tell me pseudo G-sac is seen in which condition? I can't afford much to wait because of less time still. Pseudo G-sac is seen in which condition? Yes, G-sac comes in 5 weeks. Where do you see pseudo G-sac? What are the pathologies where pseudo G-sac is seen? No, it is 5 weeks. TVS mein hi it is 5 weeks. Abdominal ultrasound always shows it later. It is TVS which is showing it at 5 weeks. Pseudo G-sac is seen in ectopic pregnancy. So G-sac is not a sign of intrauterine pregnancy, not a confirmatory sign. What is the confirmatory sign of intrauterine? That your pregnancy is intrauterine? Yolk sac. Can you see this? Yolk sac, which is the sign of confirmatory sign of intrauterine pregnancy, seen at 5.5 weeks. Correct. Good. So yolk sac is a confirmatory sign of intrauterine pregnancy, not the G-sac, remember. When I see yolk sac, now I can say this pregnancy is intrauterine. Then, but yolk sac is not a sign of viable pregnancy. Whether the pregnancy is viable or not, I don't know. Okay? Embryonic pole. This is yolk sac. Now I can see embryonic pole also. So embryonic pole is seen at 6 weeks. The confirmatory sign of a viable pregnancy is when I see the fetal heart at 6.5 weeks. This is a confirmatory sign of a viable pregnancy. The confirmatory sign of intrauterine pregnancy is yolk sac. Okay, the earliest sign that comes is G-sac. What is the difference between pseudo G-sac and true G-sac? Can I see this true G-sac is round and regular, whereas here it is not round, it changes shape. Pseudo G-sac changes shape. It is a water. So if I put a probe pressure, it changes shape. It is not round. Then there is something called as double decidual sac sign. There are two layers of decidua that can be seen around this and this. Two layers of decidua that can be seen around this G-sac. Double decidual sac sign, which is absent here. Along with yolk sac, if I can see yolk sac and embryonic pole, it looks like a double. In this G-sac, I can see one more yolk sac. So that is double bleb sign that is present here, but that is not present here. Okay? It is regular, round, doesn't change shape, it changes shape. It double decidual sac sign positive, double decidual sac sign negative. Double bleb sign positive, double bleb sign negative. Okay? Double decidual sign is seen in double decidual is in true G-sac. When it is a uterine pregnancy, then we see a double decidual sign. Okay? Identify this sign. What is this sign, everyone? Good. It's a bluish discoloration, Chadwick sign. But remember, it is bluish discoloration of vulva and cervix both. What is this sign? If I am seeing the hands are trying to approximate, they are not like this, they are approximating like a letter H. Hagar sign. Okay? So this finishes our diagnosis of pregnancy. So we are not not trying to do all the obs here. We are not trying to cover everything, but we are trying to cover last 5-year questions. Many questions I have put up, many questions I have not put up, whose theory I am telling you. Coming to antenatal care. So how many antenatal visits are needed? How many antenatal visits are needed? So minimum antenatal visits according to our guidelines is 4. Good everyone. So antenatal visits minimum are 4 visits according to our Ministry of Health and Family Welfare. WHO says minimum antenatal visits is 8. Minimum. What is the ideal number of visits that should be done? Ideal visits are 12 to 14. Minimum 4 and 8, but ideal visits are 12 to 14. Good. Very good. Majority of you know many of the things already. We are doing a revision. Good. Now you should know how to calculate expected date of delivery. Expected date of delivery is calculated using Neagle's formula, where you add 9 months and 7 days to LMP. This all of you know. I know this. But what you have to know is the Wood's modification. Remember Wood's modification. This formula is for a 28-day cycle. If questions specially mention a woman of 30-day cycle or a woman of 24-day cycle, what is EDD? In that case, you have to do Wood's modification. If it is a long cycle, you add extra days. A woman has 32-day cycle. What will be her EDD? So you calculate EDD according to Neagle's rule and you add how much days? 28 say 32. You will add 4 days extra. So in case question gives you the cycle length, there is a purpose. You need to add extra days. If the cycle is lesser than 28, you subtract those many days. So that is Wood's modification. Then GPLA calculation. Gravida para, very important. Remember, gravida includes current pregnancy. So current pregnancy is included in gravida. What is para? Pehli baat, this pregnancy, when she has come to you and she is pregnant right now, this pregnancy is not included. Second, how many times her pregnancy has crossed the viability? How many times pregnancy has crossed the viability? 20 weeks के beyond कुछ भी हुआ हो, चाहे वो preterm था or it was IUD, it was a full term, that all will be para. So para is how many times your viability has been crossed. That's it. बाद में it delivered as IUD, doesn't matter, but that will be para. Again, twins में, if a baby mother has delivered twins, para will be 1. Because pregnancy तो एक ही थी ना. P is pregnancy. So pregnancy was 1, though she delivered 2 babies. So if there is a twin, para will be 1. Okay? We'll do questions and you just have to remember all this. Current pregnancy is not included in para. It is included in gravida. Gravida means how many times she has been pregnant, irrespective of the result. Para means how many times the viability has been crossed. How to calculate gestational age? Gestational age is generally calculated only using LMP, but the best way of calculating gestational age is crown rump length. That is done only in first trimester. So the most accurate gestational age is given by crown rump length, and that is done in first trimester. If a woman comes to you in second trimester, what do you use for gestational age calculation? You use biparietal diameter. In second trimester, we can't use crown rump length. In third trimester, what do we use for gestational age? We use femur length. Which parameter is never used for gestational age calculation? Never. Abdominal circumference. Abdominal circumference of the baby is never used for gestational age. Among these, which is most sensitive, most accurate? Crown rump length. Okay? Which of the following is the best parameter for estimation of fetal age by ultrasound in first trimester? Even if they would have not written this, then also answer would have been crown rump length. Okay? A 35-week pregnant woman had delivered twins last time. What is her para and gravida? Please answer this question. Now I'll wait for all of you to answer this question. What is her para and what is her gravida? Anybody else? What is her gravida and para? Okay. Any more answers? So she has been pregnant last time. Now also she is pregnant. So she is gravida 2 and she is para 1. Correct. Absolutely. Good. Okay. Now see this question. A 34-week lady. I have included some of the NEET questions also. No, but it's not D. No, it's not D. It's not para 2. I told you, twins is always para 1. You will get one question. Definitely on GPL. Twins deliver हुए थे, it is para 1. This time she is pregnant, it is not included in para. Last pregnancy is included. Okay? Now some questions of NEET I have included because the FMGE has a habit of picking questions from NEET. 34 weeks lady using OCP since 5 months. So she had no natural cycle. She was having bleeding because of OCPs. With amenorrhea at 6 weeks, what is the best way to calculate gestational age? What will we use for gestational age calculation? Will we use her LMP? We will use CRL. Correct. As such also it is most accurate, and especially when the cycles are irregular, somebody is taking OCPs, then the best way is always CRL. Beta, what to repeat? What do you want me to repeat? Gravida para? What do you want me to repeat? So you just write down, Betu, what do you want me to repeat? Okay, meanwhile, I'll go ahead. We are almost completing 1 hour. ANC care. So minimum ANC visits we have read according to our guidelines, 4, according to WHO, 8. Ideal ANC visits we have done 12 to 14. You are answering C for which question? Okay, good. During the ANC care, we give something to prevent neural tube defects. What do we give? The drug given for neural tube defect is folic acid. So what is the dose of folic acid that is as such needed? It is 400 mcg. But some women need higher dose, जिसे हम कहते हैं therapeutic dose. So therapeutic dose of folic acid is 10 times, 4 milligram. When will we give therapeutic dose of folic acid? She is obese. Such a small dose will not get absorbed. She is obese or she has some GI absorption problem. Then I'll give higher dose. Or somebody having a history of neural tube defects in family or in previous baby. She's a high risk woman. She's a diabetic woman. We'll read diabetes and we'll see how high risk they are for neural tube defects. So diabetic women. And a woman of hemoglobinopathies. A woman of hemoglobinopathies will need folic acid not for neural tube defects but for new RBC synthesis. So there the dose will be 4 milligram. Some places you will get a 5 milligram tablet. Both are considered therapeutic dose. Remember the indications. Immunization, yes, immunization has to be done of every pregnant woman using what? TD. Tetanus, diphtheria. Now TD is used, not TT. She has to take 2 doses 1 month apart. But remember in this that if she has been vaccinated in her previous pregnancy, In previous pregnancy she got vaccinated and previous pregnancy was within 3 years. It was within 3 years. In that case, I will give only booster. So if previous pregnancy was within 3 years and she was fully vaccinated, in this pregnancy I'll give only booster. If the previous pregnancy was more than 3 years, I'll give a full dose. 2 doses 1 month apart. First dose is given as first visit. At first visit we give the first dose. Okay? What are the other preventive measures that we take? So what are we giving this women? We are giving her vaccination. We are giving her iron folic acid. So iron folic acid has to be started from the second trimester. It contains iron and folic acid. Iron here is 60 milligram iron, elemental iron, and folic acid is 500 mcg folic acid. Therapeutic doses is needed in certain conditions. Otherwise, we give iron folic acid tablet to everyone. What extra preventive measures is recommended by our government? Albendazole. So जो हमारी government recommend करती है, that all you have to know. So they have recommended deworming in second trimester of every pregnant woman. Everyone should be dewormed using albendazole single tablet of 400 milligram. So these 3 preventions have to be given to everyone. ठीक है? Next, what immunization, what vaccines are allowed, what are not. Remember, all the live vaccines we can't give. Okay, we can only give killed vaccine. Influenza can be given, hepatitis A, B given, pneumococcal given, meningococcal given, varicella, it's a live vaccine. MMR, live vaccine. HPV is not a live vaccine. We don't have much research right now in pregnancy, so we can't give it. Typhoid has 2 vaccines, Typh oral and Typh IM. Typh oral is a live vaccine, not given. Typh IM is a killed vaccine, given. Rabies is given. Rabies is not a live vaccine. It's a killed vaccine. Only one live vaccine that can be given in pregnancy, that is only one, and that is yellow fever. Yellow fever is the only live vaccine that can be given in pregnancy. Remember, rabies is not a live vaccine. Okay? Many of you mark only live vaccine that can be given in pregnancy. Rabies, no. Rabies is a killed vaccine. Okay? What else you have to do during the antenatal care? Aneuploidy screening. What is the method for screening in first trimester? NT scan plus dual marker. What are we checking in dual marker? Question number 2. What are we checking in dual marker? Beta HCG plus pregnancy associated plasma protein, PAP. These 2 we check in first trimester. If she has missed first trimester screening, she has come to you with second. What do? Either you can do triple marker, which is now not done, or you can do quadruple marker. What is done in triple and quadruple marker? Remember A, B, C. Alpha fetoprotein, beta HCG, unconjugated E से C से unconjugated estriol. For quadruple marker, what extra will you add? Can somebody tell me what do I add in quadruple marker? Rest 3 remain same. Alpha fetoprotein, beta HCG, unconjugated estriol. What extra do I add in quadruple marker? What extra do I add? Anybody? And write the complete name. What do I add? In quadruple marker, what should I add? I'm writing right now. I'm waiting for all of you to give me some answer. Which I have told you, write complete name, Virinder. What? Samina, think again. Tasmina, think again. Right? Which inhibin? What has happened to everyone? Inhibin A. It is inhibin A that is added, not B. So remember, it is A. Okay, so in quadruple marker we do inhibin A. That is the extra thing that is added. Okay? Anybody who comes high risk in these screening, we go for diagnostic. फर्स्ट ट्राइमेस्टर में डायग्नोस्टिक इज कोरियोनिक विलस सैम्पलिंग डन एट 11 to 14 वीक्स. इट इज़ अ डायग्नोस्टिक टेस्ट. ठीक है. एमनियोसेंटेसिस इज डन इन second trimester. These are the diagnostic test. There is another test that is coming that might be asked, that is NIPT, non-invasive prenatal testing. ठीक है. In NIPT, first of all, it's a screening test. It can be anywhere from 9 weeks till delivery. It can be done anywhere. What are we trying to detect? We are trying to detect free fetal DNA. That's what we are trying to detect. It is extremely sensitive. Though it is a screening test, the sensitivity is 99%. Why we don't do it in everybody? Because it is a relatively costly test. ठीक है. This is about a screening. चलो. Folic acid therapeutic dose is given in which condition do we need to give folic acid therapeutic dose? In any kind of hemolytic anemia, we will give folic acid in a higher dose. ठीक है. We are not doing all the questions because we don't have time. We have to cover a lot. I'm telling you where the previous PYQs has been asked. Abortions, one of the very favorite topic that is very frequently asked. So abortions, what is the most common cause of abortion? Talking about spontaneous abortions. The most common cause of spontaneous abortion is chromosomal aneuploidies. Chromosomal aneuploidies are the most common cause of abortion. ठीक है. बेटा YA, so history of premature delivery, history of neural tube defect में आप therapeutic dose देते हो. Not here. Preeclampsia में why will you give? या फिर low birth weight baby में why? Sickle cell anemia में you will give because RBCs are getting hemolyzed. They need folic acid for formation of new RBCs. That is why. So abortions पे आते हैं. Most common cause of spontaneous abortions is aneuploidy, chromosomal aneuploidies. Spontaneous abortion can be 5 types. What scenario will be given to you? Let's see. First scenario, os closed, bleeding present, fetal heart present. Baby is healthy. So it is threatening you. This uterus is threatening you. It is not aborted right now. So it is a threatened abortion, which you treat by using progesterone. Second question, fetal heart is present, baby is healthy, os open. As soon as os open, now you can't stop this process. It is now inevitable. Inevitable, something you can't stop. Inevitable abortion. Second, os open, fetal heart is not seen in cavity. Product of conception felt in vagina. So now abortion has started. It is incomplete abortion. Incomplete. ठीक है. Question number, situation number 2, bleeding present, os closed. When you did the ultrasound, completely empty cavity. Means abortion हुआ है, but now it is complete. Complete abortion. Next, no bleeding, os closed. Patient just came to you for scan, and on scan you saw the fetal heart is not there. It is not viable. So when it has, when the viability is gone inside the uterus, it is missed abortion. Missed because there was no bleeding, there was no sign, and baby expired within the womb. This is missed abortion. So these are the different scenarios that will be given to you, and you have to make a diagnosis. Induced abortion, I must say, the most important topic. Induced abortion. ठीक है. So induced abortion में what do you have to know? Indications exactly. So induced abortion can be done using 2 methods, medical and surgical. Medical method is allowed till what gestation? No confusion. Medical induced abortion की guideline has been given in 2023. So there should be absolutely no confusion in anything. So medical abortion is allowed only till 9 weeks according to our government guidelines. Then according to CAC, correct. Surgical method can be done anytime from first trimester to last trimester. The medical method that we give is, in our country, is only 2 tablets. Mifepristone plus misoprostol. So mifepristone plus misoprostol is the only medical method that is allowed by our country. The dose of mifepristone is 200 mg. Dose of misoprostol is 800 mcg. Single packet containing mifi and miso that has to be given in a gap of at least 24 hours. So this is the method that has to be given according to our guidelines up till 9 weeks. Surgical method can be done in first trimester and in second trimester. So when you are doing in first trimester, the surgical method is called as vacuum aspiration. Just using vacuum, using either a I have shown you in my class, manual vacuum aspiration syringe or a vacuum cannula, Carmen's cannula, you will do vacuum aspiration. In second trimester, if you are doing a surgical method, can you do a medical method in second trimester? No. Surgical method that can be done in second trimester is dilatation and curettage and evacuation. Now only vacuum aspiration is not gonna help. So dilatation and evacuation is the method that is we do in second trimester. Every line in this abortion is important, every line. What are the indications? So we have divided women into 3 categories. Category 1, everyone is allowed, even the contraceptive failure. So this contraceptive failure has given everyone a right for abortion. So up till 20 weeks, everyone is allowed for abortion, even a contraceptive failure. Category 2, only special conditions, like there is some physical or mental problem in the women, or it's a minor girl, or it's a rape victim, or pregnancy happened during a disaster, anything of this kind, allowed till 24 weeks. Yeah, it will be there. You can anytime come to YouTube and it will be there. So up till 24 weeks, special categories allowed. Does this involve contraceptive failure? No. So contraceptive failure, remember, it's very important, is allowed for termination only till 20 weeks. 20 to 24 में only this special category is allowed. तीसरा category है that who is allowed for abortion till term. She has a full right for abortion till term. Though it is not abortion till term, we will not call it, but it is counted in CSE guidelines. So what it is? Severe congenital malformation in baby. That is the only indication where we can allow abortion till term. Here you need permission of 1 RMP, here you need permission of 2 RMPs, here you need permission of a medical board. Medical board will decide whether the anomaly is significant or not. You patient will not decide. So these are the indications. Consent, if more than 18 years, consent of only women is needed. We do not need anybody else's consent. Married, unmarried, doesn't matter. Only women consent is needed, more than 18. If she is less than 18, please remember, she is less than 18 or she is mentally unfit, or she is mentally unfit. In that case, the consent of guardian. This is your PYQ. Consent of guardian is needed. Not parent, not doctor, not partner, guardian. ठीक है? Medical board basically has 3 members. If you are talking about members, बच्चे medical board में कौन होगा? Somebody who can tell you that an anomaly is there, radiologist होगा. Somebody who can tell you that yes, anomaly is very risky, pediatrician. Somebody who can support and somebody who can decide how the abortion will be taken, gynecologist. That's it. These 3 specialty form medical board, and not, in case any other specialty is needed, then it is added. Basically, medical board is because of radiologist, pediatrician and gynecologist. Okay? I have written enough on each slide because everything is very important which you have to revise. Now, so that was induced. Recurrent pregnancy loss. Incidence of recurrent pregnancy loss. What is definition? 2 or more than 2 non-consecutive. Remember, 2 or more than 2 non-consecutive loss. They don't have to be consecutive. One abortion followed by a normal delivery, again abortion. It is recurrent pregnancy loss. Okay? 2 or more than 2 non-consecutive loss. Causes. The most common cause of recurrent pregnancy loss is again aneuploidies. Do not write uterine malformation. Uterine malformation is not the most common cause of RPL. Again, aneuploidies. 40% patient will have chromosomal aneuploidies. Most common cause of second trimester recurrent pregnancy loss is uterine anomalies. In that too, most important is cervical incompetence. So second trimester recurrent pregnancy loss में uterine anomalies होता है. Overall, it is again aneuploidies. Other causes very important, APLA, जिस पे question आएगा. Another very important cause is cervical insufficiency, जिन पे question will be asked. ठीक है? What APLA? APLA के लिए we use SAPRO criteria for diagnosis. We need 1 clinical and 1 lab criteria. What is clinical criteria? Clinical criteria is either 3 spontaneous miscarriages or one miscarriage but that happened after 10 weeks, means baby grown to a sufficient size, then miscarriage happened, or severe preeclampsia at an early gestation. Any of these is present. Along with that, the lab parameter is positive lupus anticoagulant or beta 2 glycoprotein or anticardiolipin antibodies. That is APLA positive. And how do we treat APLA? Treatment of APLA is always heparin plus aspirin, and remember when it is started. Patient UPT positive. As soon as patient is UPT positive, you start heparin and aspirin both. You don't wait for seeing an intrauterine fetus, or you don't wait for cardiac activity. So as soon as she is UPT positive, you start heparin and aspirin both. That is the treatment for APLA. Okay? So once, another question that can be asked, once patient gives you this history, you get the blood test. If blood tests are high, blood tests are positive, you always repeat. When do you repeat? You always repeat after 12 weeks. Okay? Syphilis. Syphilis is a infection that can cause congenital anomalies. Okay? So it is a torch group of infections. But syphilis, generally recurrent pregnancy loss, syphilis is presents with the scenario where with each pregnancy, just give me a second, my battery is losing, just give me a second, I'll change my position. Yeah, so syphilis is a condition where with each pregnancy the prognosis gets better. Okay? So whenever there is a syphilis condition, how the patient will give you the history, that first there was abortion, second the abortion was happening at a later gestation, then there was a preterm, then there was a live birth. So with each pregnancy the prognosis keeps on increasing. Okay? Now see the question. A lady presented with recurrent abortion at 8 weeks, 11 weeks, 22 weeks. One thing that they have given is she had preeclampsia. She had preeclampsia. This thing will indicate diagnosis towards APLA. Otherwise, it can be syphilis also. TORCH does not present with recurrent pregnancy loss. TORCH group does not have recurrent pregnancy loss. Syphilis can, but syphilis mein preeclampsia will not be there. Okay? Another very commonly asked topic is cervical insufficiency. In recurrent pregnancy loss, cervical insufficiency is also asked. Remember, it's a clinical diagnosis. Okay? There is no diagnostic test for cervical insufficiency. And whenever there is cervical insufficiency, patient gives you a history. So we give cerclage. Cerclage can be history indicated cerclage. It can be ultrasound indicated cerclage. So first see the types of cerclage that will be given in cervical insufficiency. So cerclage that can be given is one given vaginally. Cerclage that, just hold on a second. Yes, so cerclage are basically of three types. One is Shirodkar, given vaginally. If you want to go higher up further, then, so one is McDonald's, that is given vaginally. If you want to further go high up, then you give Shirodkar. Okay? If the cervix is too short or your vaginal cerclage have failed, then you give laparoscopically transabdominal cerclage. So transabdominal is given only when cervix is too small or the vaginal cerclages have failed. But when do you give cerclage? When will you give? Either there is a significant history. Significant history matlab 3 or more than 3 preterms or 3 or more than 3 mid-trimester abortions. So this is a significant history. 3 is a big number. So anybody giving history of 3 or more than 3 preterms or 3 or more than 3 mid-trimester abortion, if question has given you this, don't go for ultrasound. Straight away cerclage is given at 11 to 14 weeks. At 11 to 14 weeks, yes, I'll explain. Just wait, Anna. I'll explain slowly everything. HIV, definitely. HIV is a very important topic and we'll cover HIV. Don't worry. So 3 or more than 3 preterm or mid-trimester abortion, no ultrasound needed. No ultrasound proof needed. You give cerclage. That is history indicated. What is ultrasound indicated cerclage? When there is history of 1 preterm, or there is history of 1 cervical surgery, ठीक है, or there is history of 1 mid-trimester abortion. In all these, you are not very sure whether there is cervical insufficiency or not. So you do ultrasound. Along with history, you do ultrasound, and if ultrasound shows short cervix, then you give cerclage. इसे हम कहते हैं ultrasound indicated cerclage. So this history plus a short cervix which is less than 2.5 centimeter on ultrasound, you give cerclage. Significant history, no ultrasound needed, straight away cerclage. History indicated cerclage. ठीक है? Contraindication of cerclage: whenever women is already in preterm labor, her membranes have ruptured, or there is bleeding, or you don't want to save this fetus because either fetus is compromised, some lethal defect, or it is dead. There is no use of keeping the fetus inside. In those cases, you don't give cerclage. ठीक है? So a gravida 2 comes to you at 18 weeks for anomaly scan, and she saw cervix is small. So which among the following is an absolute contraindication for cerclage? Advanced age, positive fetal fibronectin मतलब होता है it's a sign that she is going in preterm labor. Membranes bulging or ruptured membrane. Ruptured membrane में we can't give cerclage. Okay? A patient of rape victim present at 22 weeks. What will be your advice? 20. Remember हमारे पास we have 3 categories: 20 weeks, 20 to 24 weeks, and 24 weeks से term. Rape victim comes in this category. So she is allowed for pregnancy termination. What is appropriate step according to MTP for a married lady with failed contraception at 26 weeks? At 26 weeks, a failed contraception. So always read answers slowly. Cerclage when? Till insert. It is inserted till 37 weeks. Cerclage, once you have inserted it, you open it only at 37 weeks when the baby is mature. So will a woman of contraception failure is allowed for MTP at 26 weeks? No. She is allowed only till 24 weeks. So if no anomaly, she has to continue the pregnancy. Good. We can't just allow her pregnancy, allow her termination. Which of the following is required for MTP at 21 weeks? 21 weeks पे fetus diagnosed with meningomyelocele. So at 21 weeks, whose permission we need? 2 doctors. But remember, read all the options. Many of you will just go and straight away mark this. But no. Always read all the options. Her consent and opinion of 2 doctors. These kind of questions, you know the answer, but you will just mark them incorrect when you are in hurry. So don't be in hurry. Her consent and opinion of 2 doctors, that is what we need. Okay? Patient at 8 weeks of gestation for MTP, what method will be used? India has only one method, MIFI and MISO. Okay? 36-year-old woman, gravida 3, para 2, 7 weeks, seeking for MTP. As per CSE guideline, what drugs will be used? MIFI and MISO. So this question has been asked so many times. So this finishes our abortion. Now we'll go for ectopic pregnancy. So question gives you UPT positive in shock. Remember, UPT positive in shock, it is a case of ectopic unless and until proved otherwise. So anybody in early pregnancy with shock, it is always ectopic. Or question will give you UPT positive, pain abdomen and spotting. So this is a very typical triad for ectopic. So if question has given you spotting hai, early pregnancy hai, pain hai, mark ectopic, it is ectopic. Okay. What are the diagnostic tests for ectopic? The diagnostic test for ectopic is TVS. TVS is the diagnostic test for ectopic pregnancy. Okay. Treatment. The treatment for ectopic pregnancy can be, it can be medical. No, in the last what we read, see, after 20 weeks you need permission of 2 doctors. Okay? Yes, I told you cerclage is put. It has to be put at 11 to 14 weeks till 37 weeks. 37 weeks pe you have to remove it. Okay. What is the treatment for ectopic? Ectopic can be treated in 3 ways. One is conservative. You don't do anything. When the sac is small, when the beta HCG is also less, when there is no cardiac activity, and the patient is stable, I don't do anything. I will just follow her up. I know pregnancy will dissolve by itself. In some cases, I will need methotrexate. Remember, single dose IM is the treatment. Multi dose नहीं देते हैं, single dose देते हैं. When my sac is small, cardiac activity भी absent है, patient भी stable है, but somehow the beta ECG is higher. It is more than 1000, but it is more than 1000, but it is less than 5000. So when it is this high, I'll give single dose methotrexate. When will I do surgical treatment? Either my sac is high, bigger, or the beta ECG is more, or the cardiac activity, anyone is present, or the cardiac activity is present, or the patient is unstable, any of these is present, I will do a surgical management, which is laparoscopic, remove the tube. Why? It is a damaged tube. Why will you save it? Why do you want to save it? Laparoscopic salpingectomy. Don't save that tube. Again, ectopic will happen. So laparoscopic salpingectomy is done. How do you follow up? I always follow up after doing medical management. I follow up whether my medicine is working or not using hormone beta HCG. So using HCG, I will keep following whether my medicines are working fine or not. Okay? A woman at 22 weeks present with profuse vaginal bleeding. Her BP and glucose. See, ectopic में I always told you there is always spotting. Ectopic में हमेशा spotting होती है. Why? See, this is the tube. So if it ruptures, the blood will go into the peritoneum. So why ectopic spotting is happening? Because endometrium has still got thickened. Endometrium didn't knew that pregnancy is ectopic. It got thickened. And when it bleeds, patient will have spotting. There is only one ectopic which has profuse bleeding. Only one. When ectopic is here. When it is here, if it ruptures, it will profusely bleed. So it is only cervical ectopic that will present with profuse bleeding. Rest all will have only spotting. In case bleeding happen in them, it will be intraperitoneal bleed. Patient of infertility 3 years has 6 weeks amenorrhea, present with spotting. Adnexal mass will present, but cardiac activity is mass with fetal pole, but cardiac activity absent. Size is this, HCG is this. What is the treatment? So cardiac activity absent, size is small, HCG is also less. What will I give? I'll give single dose methotrexate, not multiple dose. Single dose is the treatment. Multiple dose is given in gestational trophoblastic diseases. GTD. What is GTD? GTD is a abnormal proliferation of trophoblast. Abnormal trophoblast proliferation is GTD. It can be benign. So benign are molar pregnancy, complete and partial, and it can be malignant. Malignant हम कहते हैं GTN. All malignant are called GTN, which is invasive mole, placental site trophoblastic tumor, epithelioid tumor, and choriocarcinoma. These 4 are GTN. ठीक है? How does molar present? Molar presents with, again, same pregnancy with spotting plus grape-like vesicles are released. Patient will have grape-like vesicles. Uterus is enlarged. It is more than the gestational age. Since HCG is extremely high, patient will have features of hyperthyroidism. Patient will have features of early preeclampsia. How do you diagnose? So ultrasound can indicate you the diagnosis. Ultrasound use करते हैं because ultrasound will show you typical. We'll see the question. Snowstorm appearance. Typical snowstorm appearance in molar. And along with that, you'll see big, huge theca lutein cyst. Big, huge theca lutein cyst and snowstorm is nothing but molar. But that is not diagnostic. Diagnostic is always histopathology. For both molar and GTN, the diagnostic confirm is by histopathology. What is the treatment? Now be very cautious here. Molar ka treatment is never methotrexate. Molar ka treatment is suction and evacuation. Suck out everything, that is molar. Okay? In complete and partial mole, both suction and evacuation. The treatment for GTN is chemotherapy. Okay? You use either methotrexate. Here you will give multiple dose. You give multi-dose methotrexate at day 1, 3, 5, 7. Okay? And if it's a high risk disease, If the prognosis is bad, then you give a regime called as EMACO regime. You don't have to remember the duration and the dose, but remember EMACO in case the prognostic scoring is bad. Bad matlab more than 7. Otherwise, give multi-dose methotrexate. But in molar, suction evacuation is sufficient. How will you follow up? Once we have suctioned out everything, whether everything is out or not, how will I follow up? The hormone used for follow-up is beta HCG. It's a trophoblastic disease, no? So we'll use that hormone only. A 28-year-old woman with snowstorm appearance with multiple cystic spaces, beta HCG is very elevated. What is the appropriate management? First of all, what is the diagnosis? Molar. So when you see molar, what will be the ideal treatment? Repeat ultrasound, methotrexate, dilation and curettage. Immediate termination of pregnancy, it's not exactly the pregnancy that you're terminating. You'll just suck out everything. Dilatation and curettage. This question was asked last year. 46XX P57KIP2 negative indicate which pathology? Very difficult question, I must say. So this is a gene that is basically present in the chromosomes that you have derived from the mother. Maternally derived gene. See, you have a pair of chromosomes. One you have got from father and one you have got from mother. Isn't it? So maternally derived chromosome has this particular gene which is present in everyone. But it will be absent in which pathology? Where maternal nucleus was not there. There is a pathology where maternal nucleus is not there. The sperms come and ovulate an empty ovum. There this gene will be negative. What is this pathology? Complete mole. Complete mole mein there is no nucleus, maternal chromosomes are not there, that is why this gene is absent. Partial mole is triploid. It has maternal nucleus, it has 2 sperms. So it is triploid. It has maternal genes. So this gene is positive. Whereas complete mole is diploid. But whatever chromosomes are there, that is paternal chromosomes. So no male maternal chromosomes are there. So it is there in complete mole, this gene is absent. Okay? We complete the early pregnancy and its complications. Now we have come to the medical complications in pregnancy. We have to go a little faster. We'll just keep on revising the important points, do few questions and then we are done. Okay? What happened to glucose physiology in pregnancy? What changes happen in the glucose in our pregnancy? So in pregnancy, women develop insulin resistance, isn't it? Because of that insulin resistance, what will happen? Women will have fasting hypoglycemia. Whenever she gets up, she has transferred all sugar to the baby. That is why she is fasting hypoglycemia. When she eats up, her sugar will rise. Why? Because there is insulin resistance. Postprandial hyperglycemia. How she compensates insulin resistance? By increasing her insulin levels. So this is a normal glucose physiology that happens in a pregnant woman. Okay? Screening and test and time. So screening for diabetes is done twice. One at first visit and another one is done at 24 to 28 weeks. So we have to do screening twice. Which test do we use? What test do we use for screening? We use according to DIPSI, OGTT, where we give 75 gram glucose and measure the sugar after 2 hours. And if the sugar values are more than 140, that is GDM, gestational diabetes mellitus. It is irrespective of the gestational age. चाहे वो 8 weeks की हो या 20 weeks या 24 weeks, it is irrespective of gestational age. ठीक है? If the sugar values are very high, it means her OGTT test shows sugar more than 200, or her fasting sugar is more than 126, or her HbA1c is more than 6.5, then we will call her overt, matlab pre-diabetic. So whether she is pre-diabetic or she became diabetic during pregnancy, that depends on sugar values. That does not depend on gestational age. Okay? If sugar values are high, she is pre-diabetic. If sugar values are high but not much high, she is GDM. Okay? What are the risks to fetus when woman is pre-diabetic? When she has a diabetes, already existing diabetes. She has risk of abortions. She has risk of congenital anomalies. Then there is a risk of a big baby, macrosomia. Then there is a risk of polyhydramnios. and all the risks that happen because of big baby, PPH, difficult deliver, shoulder dystocia, everything. Risk to the baby in GDM. GDM में ये सारे risk है. Baby is big, so there will be a difficult labor. There is polyhydramnios. But remember, GDM never cause abortion. It never cause anomalies. Anomaly and abortion does not happen in GDM. Anomaly and abortion happen only in a diabetic woman. GDM होता है वो diabetes that happen because of insulin resistance only during pregnancy. Once the pregnancy is gone, diabetes is gone. That is GDM. Sugars are never very high. That is why there is no abortion. That is why there is no anomaly. Anomaly and abortion only happen in a diabetic woman, pre-diabetic. What anomalies? The most common anomaly that happen in this woman is a cardiac anomaly. Okay? So most common anomaly that happen in a diabetic mother is VSD. That is the most common anomaly. Heart is most commonly involved, followed by neural tube defects. That is why you are giving therapeutic folic acid here. Most specific anomaly in heart, most specific is TGA, transposition of great arteries. Overall, most specific anomaly that is seen generally in diabetic mother only, otherwise they are not seen, is sacral agenesis. Sacral agenesis is very specific of diabetic mother. Remember, it is not the most common anomaly. Most common is VSD. It is most specific, not seen anywhere, only seen in diabetic mother. Okay? What is the drug of choice? The drug of choice for diabetes is always insulin. Though you start with diet and exercise first, but drug of choice is insulin, especially less than 20 weeks. Less than 20 weeks pe you don't start metformin. Okay, so insulin is the drug of choice. When you deliver GDM, remember, if the GDM is controlled, whether it is controlled on insulin or it is controlled on diet, doesn't matter. If it is controlled, you deliver at 39 weeks. If it is not controlled, you deliver at 37 weeks. So if she is controlled on insulin, then also if it is controlled, we will always deliver at 39 weeks. Premature delivery we never do in diabetes. Okay? Which of the following statement regarding carbohydrate metabolism in pregnancy is incorrect? There is fasting hypoglycemia, postprandial hyperglycemia, correct hai. Insulin requirement increase as the pregnancy advance, yes, because resistance hai. There is increase in peripheral insulin resistance, correct, but insulin secretion decrease, no, insulin secretion increase. That is typical of pregnancy. Okay? A 30-year-old primary gravida at sea, 18 weeks, come for antenatal checkup. Random blood glucose is so high, more than 200. Further testing mein HbA1c fasting is 146. Fasting is again very high. HbA1c is so high. What is her diagnosis? At 18 weeks, it doesn't matter what are her weeks, such a high sugar values, she is over diabetes. She is not gestational because her sugar values are very high. High मतलब मालूम है ना हमको? Random blood sugar more than 200. Your OGTT test is more than 200. Your HbA1c is more than 6.5, and your fasting blood sugar is more than 126. This is high sugar. Screening method for GDM is recommended between एक तो first visit पे, दूसरा is 24 to 28 weeks. Now we come to hypertension in pregnancy. Hypertension in pregnancy. So up till now everything is going clear. We are going fast, but we have to see 1.5 hours have passed. We have not covered even half of obstetrics. I think we might have to leave gynecology, or instead of doing questions in gynecology, what we will do is we will just brush up important points. Causes, how to differentiate pathology. Gynae mein yahi aata hai. They will give you a scenario of primary amenorrhea, identify the cause. They will give you an abnormal uterine bleeding, identify the cause. They'll give you a PCOD picture, identify the cause. So we'll just see how to identify the causes. Okay. Hypertension in pregnancy. What is the pathophysiology of hypertension? Why does it happen? Remember, there is improper invasion of spiral arterioles. Spiral arterioles are not invaded properly by endovascular trophoblast. That is the reason for hypertension that happened during pregnancy. If hypertension is present less than 20 weeks. Now here gestational age is important. Diabetes में it is not. So if hypertension develops at less than 20 weeks, it is chronic. It is not because of pregnancy. Patient was already hypertensive. But if hypertension develops after 20 weeks, it is pregnancy induced. Now pregnancy induced hypertension can be gestational hypertension when only BP is high. But along with BP, if there is proteinuria, what is significant proteinuria definition? More than 300 milligram in 24 hours. ठीक है? Or urine dipstick more than equal to +1. That is significant. So if there is proteinuria or a sign of organ dysfunction, that is preeclampsia. So preeclampsia develops after 20 weeks. What are the signs of severe preeclampsia? When do we call it severe? When BP is more than 160 by 110, or BP is not so high but there are signs of organ dysfunction, यानी कि LFT deranged, KFT deranged, or patient is showing you cerebral symptoms. That all is sign of severe. Cerebral symptoms like headache, convulsions, or IUGR oligo. They all are signs of severe preeclampsia. They are showing you some organ involvement. Antihypertensive of choice. So antihypertensive of choice in a non-severe case is oral labetalol. In non-severe cases. And in severe cases, IV labetalol. So drug of choice is always labetalol. Labetalol cannot be used in patients of asthma, and it cannot be used in patients of myocardial damage, in heart blocks. So in these cases, we can't use labetalol. We have to use other drugs, which is in non-severe cases, we will use methyl dopa or calcium channel blockers. ठीक है? Convulsions. In convulsions start happening, it is now eclampsia. So what will be the drug of choice for eclampsia? Maxilf. Without doubt, the drug of choice for eclampsia is always Maxilf. What is the dose? The loading dose is 14 ग्राम. ठीक है? 14 ग्राम को कैसे देते हैं? 4 ग्राम हम IV देते हैं प्लस 10 ग्राम हम IM देते हैं, and followed by continuation dose of 5 gram every 4 hours. 5 gram every 4 hours till 24 hours post delivery or till 24 hours of last dose. It's a toxic drug, so it can cause toxicity. If it is given in a very high dose, it can cause toxicity. What is the signs of toxicity? The first sign of Maxilf toxicity is loss of DTR. Second sign is respiratory depression. These are the signs of toxicity. So whenever we are coming for injection every 4 hours we have to monitor these for toxicity. So every 4 hours when we are coming for a repeat injection, check DTR, check respiratory rate, also check urine output. Because Maxilf is excreted from urine, so always check urine output. If the toxicity happens, what is the antidote? Calcium gluconate. That is the antidote. Okay? This is all you have to know about hypertension in pregnancy. See, 34-year-old woman comes to with preeclampsia at 28 weeks. She asks her obstetrician what could be the cause. So cause is poor invasion by extravillus. So basically trophoblast दो तरह का होता है. One that forms the villi and one that doesn't form villi. उसे हम बोलते हैं extravillus. तो extravillus का what is the function of extravillus? One is invading the vessels, endovascular. Another one is invading the muscularis layer, interstitial. So both are extravillus. So poor invasion by extravillus trophoblast of spiral arterioles. That is the reason for preeclampsia. 34-year-old woman advised for ultrasound, double marker, that's a NEET PG question. When to stop Maxilf? Maxilf has to be stopped when DTR present, it's a good sign. Respiratory rate is more than 18, good sign. Urine output. When urine output should be 100 ml in 4 hours. आप जब 4 घंटे में आ रहे हो, when you are coming in every 4 hours for the Maxilf injection, it should be 100 ml. So if it is less, stop the Maxilf. Visual disturbance तो severe preeclampsia है, इसमें आपको Maxilf देना है. You have to give Maxilf there. Okay. Okay. A pregnant female with asthma presents with hypertension. Drug to be used. So in asthma, we can't use labetalol. In pregnancy, certain antihypertensives are contraindicated, like ACE inhibitors, AT antagonist, statins. They all are contraindicated. We can't give ACE inhibitors. So drug of choice is nifedipine. Okay. This is a very important question. A primey at 34 weeks, BP high है उसका. Now her blood test. SGOT-PT is high. Normally it is 40. LDH is high. LDH high matlab it's a sign of hemolysis. LDH is an enzyme present in RBC, so it's a sign of hemolysis. Platelets are low. It is less than 1 lakh. है ना? So it means along with high BP, her liver enzymes are elevated, her platelets are low, and her RBCs are going hemolysis. What it is? HELLP syndrome. Elevated liver enzyme, low platelets, and HC hemolysis. All three are present, that is HELLP syndrome. Why it is not hepatitis? Hepatitis may SGOT-PT are more than 2000. It is very high. Acute fatty liver may it is a liver failure. So liver failure may there will be coagulation derangement. There will be high ammonia level. Patient will be showing psychotic symptoms. Very low sugar because it is a liver failure. So this is HELLP syndrome. Cholestasis is a condition which will always present with itching first and high bile acids. When high bile acids are given, that is cholestasis. Okay? So this finishes our hypertension. Now we come to anemia in pregnancy. What is the definition of anemia in pregnancy? Anemia is less than 11 gram per dl. That is anemia. So anemia can happen in pregnancy because of hemodilution. Okay? We always grade anemia as mild, moderate, severe. Mild is 10 to 11, moderate is 7 to 10, and less than 7 is severe. You always give iron prophylaxis. आपका पेशेंट है? हाँ पेशेंट है. आपका? ठीक है. आप कटिंग करो. There is always iron prophylaxis that you are supposed to give. आप उसका मेनू पेशेंट देखो. लाइव चल रहा है क्या? So you always give iron prophylaxis to patient so that she doesn't develop anemia starting from 14 weeks. It is to be given everyone after 14 weeks. What do you give? We have already discussed iron folic acid tablets. Okay? So iron folic acid has 60 milligram elemental iron that you have to know. There is no excuse for forgetting this. And 500 mcg of folic acid. कितने दिन के लिए देते हैं? It is given for 180 days. 180 days while she is pregnant and added 180 days postpartum. So it is total given for 360 days. 180 plus 180. ठीक है? Treatment. Now treatment depends upon. So is my this getting stuck or something? Is it getting stuck too much? Can someone tell me if it is getting stuck? I'm connected through Wi-Fi. What is the treatment? Treatment depends upon severity and treatment depends upon gestational age. Remember, whenever it is mild or moderate anemia in early gestation should always be treated by oral tablets. Same iron folic acid tablets are given too. But if it is a late gestation, we can't give oral. We don't have time. So in late gestation, we give IV iron. But in case of severe anemia, in case of early gestation, we give IV iron. In case of late gestation, severe anemia, late gestation, she can go in heart failure. We give blood transfusion. Very severe means hemoglobin less than 5. No matter what the gestation is, you will give blood transfusion. Otherwise, she will undergo heart failure. Okay? Okay? I think, is this getting stuck? Please can someone tell me if my video is getting stuck? IV iron only हेलो, ये बार बार स्टक हो रहा है क्या? एक बार आप देखना. हाँ, देख के बताना एक मिनट. Only two types of IVRN is available now. ठीक है, so now IMRN is obsolete. Only two IVRNs are available: sucrose and carboxymaltose. These are the only two IVRNs that is now available with us. ठीक है, a patient 2 months pregnancy with anemia, hemoglobin 9. Hello, ठीक. Okay, thank you. So they are correcting it. Meanwhile, yeah. So whenever hemoglobin is 9, anemia is in first trimester, you will treat it in first trimester, not from 14 weeks. 14 weeks से prophylaxis देते हैं. So it means, can we give oral iron in first trimester? Yes. You can't give IV iron in first trimester, but oral iron you can definitely give in first trimester. ठीक है? So we have completed we have completed diabetes, anemia, and hypertension, the most important one. Now we'll go for complicated pregnancies. Antepartum hemorrhage. So antepartum hemorrhage, I think now it will be better. It is stuck. So talking about, so there are basically two causes of antepartum hemorrhage, and that is placenta previa and abruption. Placenta previa means it's a low lying placenta. So see, if it is just in the lower segment, that is marginal. ठीक है, if it is in lower segment and touching the cervix incompletely, it is incomplete. Completely covering the cervix, it is complete. So you have to know the various classification. ये Brown's classification of placenta previa you should know. Now how the question will give you, presentation of placenta previa is bleeding, but remember, uterus is relaxed. It is never tense, non-tender. It is soft, no pain. It is specifically not associated with pain. So whenever question give you high bleeding, no pain, relaxed uterus, that is placenta previa. Placenta previa की bleeding stop by itself. ठीक है? So you always treat it conservatively. But remember, placenta tends to, as uterus enlarges, placenta tend to ascend up. So maybe you diagnose placenta previa at 28 weeks. If you repeat the scan, you will see it has shifted up. इसे हम कहते हैं placental migration. Because of placental migration, you always have to reconfirm your diagnosis before making a decision. So before making any decision, always follow up using ultrasound, because it tends to ascend up. So when is follow-up ultrasound done? Once you have diagnosed placenta previa, repeat ultrasound is always done at 32 weeks to reconfirm, and then at 36 weeks to finally decide the mode of delivery. If it is placenta previa, even at 36 weeks, then you have to deliver by LSCS at 38 weeks. So placenta previa has to be delivered at 38 weeks by LSCS. But you always first reconfirm by doing scan at 32 weeks and at 36 weeks. Then you decide for cesarean. The presentation is smooth, relaxed, non-tender uterus. Abruption is completely different. Now let me see, I have tried to resolve my issue. Abruption is completely different from previa. It is premature separation of a normally situated placenta. Since the blood keeps on getting collected behind abruption, it is always painful. Bleeding along with pain. Uterus is rigid. It is tight. Rigid uterus. Question might write board like rigidity. The fetal parts are not palpable. And what else will be there? It will be tender to touch. Completely opposite of previa. Here you can't wait because there is high risk of fetal death, there is high risk of DIC. Abruption is the most common cause of DIC in pregnancy. Most common cause. Other causes are DIC, sepsis, IUD, amniotic fluid embolism. They all can cause DIC, but this is the most common cause. So you have to immediately terminate. You can't continue with this pregnancy, you have to terminate, and the mode of delivery should be vaginal. Since there is a risk of DIC, the mode of delivery is vaginal unless there is fetal distress. Obviously, if there is, I should write down here, if there is fetal distress or if there is maternal hypotension. In two condition you can't go for vaginal. These are the only two conditions where you will go for LSCS. Otherwise, mode of delivery in abruption should always be vaginal. Okay? Please let me know everyone, is it going fine now? Is the video going fine now? Please let me know if it is going fine right now. So this was a question of last year. 22-week ultrasound showed marginal. तो उसने marginal दिखाया. When will you reassess? Why will you reassess? Because of migration. I will reassess at 32. Because it might have shifted up. Identify this image of placenta previa. Yes, it is previa, but which one? It is reaching up till the os. Okay, so it is marginal. A gravida to para when present with abdominal pain, bleeding with pain. She occasionally smokes but does not consume alcohol. On examination, pulse is normal, BP is high. She has a tense abdomen. What is the diagnosis? Pain with bleeding, no previa. Hydramnios, there will be no bleeding. Abruptio placenta. है ना? ठीक है? Now we come to RH negative. I hope now it is not getting stuck. Can please someone tell me? RH negative pregnancy. So when the mother is RH negative and baby inside is RH positive, there are chances of hemolysis. Okay? So we always check in RH negative women for formation of any antibodies. So ICT test is done at the first visit, always. ICT is done for checking any antibodies in the first visit and it is repeated at 28 weeks. At the first visit and at 28 weeks we do ICT. And in case it comes negative, it means mother has not formed antibodies. So remember, when mother has not formed antibodies, ICT is negative at 28 weeks, we give an injection called as anti-D. Anti-D injection is given so that she doesn't form antibodies. वो बनाए ही ना. But for that, she should be ICT negative. If someone is ICT positive, why will I give an anti-D injection? She has already formed antibodies. So ICT negative women is given anti-D at 28 weeks and the dose is 300 mcg. This is repeated again once she delivers. So delivery is a very big sensitizing event. So I will, once she delivers within 72 hours, I'll give the anti-D again and the dose is again 300 mcg. But here also I have to remember, now I have the baby. So if I'll give anti-D only when the baby's blood group is positive, only when the baby is DCT, means direct cum test negative. So if the baby is positive and baby is direct cum test negative, means there are no antibodies, then only I'll give anti-D. If baby is RH negative, no harm, why will I give? If baby is DCT positive, already the antibodies have formed, no use of giving anti-D. So anti-D only given when baby is positive and DCT negative. There are certain, so these are the two times when I will give anti-D. But there are certain sensitizing events that can happen during the pregnancy. And that time also I have to give anti-D. Sensitizing events are like abortions. Or some bleeding like you did chorionic villus sampling. You did amniocentesis. You did external cephalic version. They all are the sensitizing event and you have to cover them using anti-D. What will be the dosage now? Anything done at less than 20 weeks, dosage is 150, half. Anything done after 20 weeks, dosage is this one. Anything after 20 weeks, dosage is 300 mcg. Any procedure done before 20 weeks, dosage is 150 mcg. I'm again looking here and here because I'm looking for questions. So if you have a doubt, please let me know. Okay, that is why I'm checking my message again and again. Okay? So this is how you prevent antibody formation. Suppose somebody is ICT positive. Now this prevention is not gonna help. Now giving anti-D is not gonna help. Now you have to treat. You have to save the baby from hemolysis. What will you do now? So in case somebody is ICT positive, antibody has formed. She has formed antibody. What will I do? Every 4 weeks I'll do titer. I'll do titer for antibodies every 4 weeks. As soon as the threshold is crossed, which is 1:16, now the baby is very much at risk of anemia. And if the baby has developed anemia, I will have to deliver. How will I know baby is developing anemia? I can't do blood test in an intrauterine baby by doing MCV Doppler. Middle cerebral artery Doppler will tell me if its velocity, peak systolic velocity is increased, blood flow to the brain is increased, it means it's anemic. Anemia may blood flow to the brain increase so that there is no hypoxia. So if MCA PSV is increased, it means baby is developing anemia, or there is high drops. So once the titers are crossed, I'll do ultrasound every 2 weeks. And if any of these develop, I will either deliver, if it is mature. If it is very immature, I will do intrauterine blood transfusion. If it is more than 34 weeks, I will deliver. If less than that, I will do intrauterine blood transfusion. How will I know anemia? By MCA Doppler or by hydrops fetalis? This is the question. Fetal anemia is monitored by fetal anemia, middle cerebral artery. Whenever there is anemia in body, blood flow to the brain increase to save it from hypoxia, the most important organ. So middle cerebral artery blood flow rise, peak systolic velocity rise. That is how I monitor. What is the antenatal dose of anti-D given in Rh negative after chorionic villus sampling? Chorionic villus sampling, please tell me. Chorionic villus sampling is done in first trimester. So, how much will be the dose? Correct, 150 mcg. Anything done less than 20 weeks, 150 mcg. After that, 300 mcg. Okay? So, we have finished Rh negative pregnancy. Now, multiple pregnancy. After that, in half an hour, we will complete the labor. Okay? Gynecology, I don't think so, will be completed in 2 hours. In case we'll get time, we'll do another session for gynecology. Okay? Multiple pregnancy. So, multiple pregnancy means that there are twins. Multiple pregnancy can be monozygotic from the single zygote, or it can be dizygotic. Which one is most common? Dizygotic. 2 ovaries fertilized by 2 sperms is dizygotic. Okay, that is more common. The incidence of twin is told to us by Helen's rule. That says that the incidence is 1:80 n minus 1. N minus n matlab number of fetuses. If the fetus is 2, incidence is 1:80. If the fetuses are 3, I want to know the incidence of triplet. 3 minus 1, 1:80. 3 minus 1, 1:6,400. So that is how I calculate the incidence of each type of multiple pregnancy using Helen's rule. Most common type of twin is dizygotic. Remember, dizygotic is always diamniotic dichorionic. It is always diamniotic dichorionic. Monozygotic is the one which is formed from a single zygote, but later it divides. Now, which type it will be, it depends upon when is it getting cleaved. When it is getting cleaved, that will decide the type of chorionicity. So, if it is getting cleaved very early, while it is in the tubes, from day 1 to day 3, if it is getting cleaved, diamniotic dichorionic. If it is getting cleaved a little later, D4 to D8, I have told mnemonic to everyone to remember that. D4 to D8, now it is diamniotic but monochorionic. Now, day 8 से day 13 पे they are getting cleaved. Monoamniotic, monochorionic. After day 13, they are getting cleaved. Siamese twins or conjoined twins. So, among these monozygotic twins, which cleavage is most common? Among these, this one. Overall, this is most common. Because dizygotic are way common than monozygotic, and dizygotic are always diamniotic dichorionic. But if the question is asked in monozygotic pregnancy, which is most common, this type is most common. Monochorionic twins have a special complications that can happen. So it is very important to know the chorionicity in very early gestation. So detection of chorionicity is done at 11 to 14 weeks. Okay, using ultrasound. So if the ultrasound is showing me since monochorionic twins have high rate of complications, which is twin to twin transfusion, twin anemia, polycythemia, and twin reversed artery perfusion. They are very specific only to monochorionic. I have to know the chorionicity. So chorionicity is done at 11 to 14 weeks. Okay? If between two twins I can see this peak kind of tissue, there is a tissue between two twins. इसे हम कहते हैं twin peak sign. Twin peak sign means dichorionic. If there is no tissue, if the separation is like this, inverted T, monochorionic. So inverted T is monochorionic, whereas twin peak is dichorionic. And monochorionic, since the complication rate is high and the fetus can also die, I have to monitor this pregnancy every 2 weeks. I have to monitor monochorionic from 2 weeks. That is why knowing chorionicity is extremely important. When to deliver? They have to be delivered before time. This is the gestational ages at which these of the twins are delivered. Important is the mode of delivery. The mode of delivery which is important is if both are kyphlic, both the babies are kyphlic, you always look at the first twin. If the first twin is kyphlic, you will go for vaginal delivery, no problem. Okay? But if first is not kyphlic, it doesn't matter what the second twin is. Doesn't matter. It will always be cesarean. So if both are kyphlic, go for vaginal delivery. If first is kyphlic, you will go for vaginal, but second is breech. First kyphlic, second breech. What do we do? Vaginal delivery with internal podalic version. Second twin in breech or transverse is the only indication for internal podalic version. If first twin is non-kyphlic, be it transverse, be it breech, first twin, then answer is always LSCS. Okay? See this question. What is the mode of delivery in this twin? First twin kaun sa hota hai? The one near the cervix. The one near the cervix is first. So this one is first, which is breech. Mode of delivery will be LSCS. Okay? Now question. Twin pregnancy where one twin is 1 month older, one twin is 1 month older than other twin. It is called. So one twin was already growing and suddenly mother got pregnant again, which is not possible in humans. But in case it happens, an arbitrary scenario, mother was already pregnant, 4 weeks she was pregnant, her fetus was growing, she became pregnant again. That is superfetation. Fetus over another fetus. One was already growing and you became pregnant again in the next cycle. That is superfetation. Okay? A woman gave birth to twins. Husband says children do not belong to him. DNA analysis shows that one child belongs to him. How is it possible? It is possible if she ovulated twice in the same cycle. Same cycle mein she released 2 eggs. But the act of coitus through which she became pregnant were different. These acts of coitus were separated by maybe a day or maybe few hours. That is possible, and that is result in heteropaternity. Twins from 2 fathers, because the act of coitus were 2. Superfecundation. So superfecundation mein twins are not the age of twin is same. It is not separated by 4 weeks or 5 weeks. They are separated only by few hours. The act of coitus are different. But in fetation, the cycle is different. In different cycle, she ovulated again. It is not seen in humans. Okay? Now coming to, just give me a second. Yeah. Okay. Infections in pregnancy. See, infections in pregnancy, may they will give you a scenario by seeing specific signs. See, IUGR, jaundice, this is something which is there in all the infections. ठीक है, तो torch group of infections specially cause congenital anomalies. You have to look at specific signs that will indicate that infection. So if question has given you chorioretinitis, intracranial calcification and hydrocephalus. Hydrocephalus is given, toxoplasmosis. Hydrocephalus is present in toxoplasmosis. If question has given is same chorioretinitis, intracranial calcification but microcephaly, not hydrocephalus, it is CMV. And CMV may question will always give you sensory neural hearing loss and thrombocytopenia. Now question give you sensory neural hearing loss, microcephaly and cardiac defects, rubella. So rubella may question will give you microcephaly, sensory neural hearing loss, heart defect and cataract, rubella. So look for these few indications that are indicating that particular infection. Okay? ठीक है, so yes, again if the question gives you, where it is, cerebral cortical atrophy, if question gives you atrophy, limb hypoplasia, skin defects, cataract, again that is varicella. So varicella will have scarring of skin, limb atrophy, that is varicella. If question gives you anemia, fetal anemia, hydrops, that is parvovirus. If question gives you perforated palate, cleft palate, saber shin, maculopapular rash, Hutchinson tooth are tooth like this, all that is syphilis. So look for those specific signs that will be indicating that infection. Okay? What is the most teratogenic torch group of infections? Which is most teratogenic? Rubella. Rubella has highest antenatal transmission, it is most teratogenic. Which has highest perinatal transmission? Perinatal transmission matlab transmission during delivery. Which has the highest perinatal transmission? Herpes and varicella. Highest perinatal transmission, leading to neonatal herpes and neonatal varicella. Toxoplasmosis and CMV have a very high transmission in third trimester, but they don't cause anomaly in third trimester. Anomaly happen only when transmitted in first trimester. And since rubella is most teratogenic, anybody who is not immune to rubella, matlab anybody who is rubella IgG negative, should always be immunized. But once she has delivered, since you can't give rubella vaccination during pregnancy, it's a live vaccine. Once she has delivered, you will immunize her. After immunization, she should avoid pregnancy for 1 month. So after rubella vaccine, pregnancy should always be avoided for 1 month. Okay? Now someone was asking me about HIV. HIV testing in pregnancy is universal. It has to be done in everyone, but it is opt-out technique, means she can opt out if she wants to. The screening is done by a ELISA, but confirmation is by Western blot. Whom do we treat? Since 2017, NACO ने कहा है treat all. Irrespective of the CD4 count, irrespective of the viral load, you treat everyone using TLD, tenofovir, lamivudine, dolutegravir. Using these three, you treat everyone irrespective of trimester, irrespective of pregnancy, irrespective of viral load. Treat all. Okay? There are certain steps you do for preventing mother to child transmission. Okay? So to prevent mother to child transmission, see, whenever question is asked which has highest antenatal transmission, never mark HIV. HIV has a transmission of 30%. Rubella has a transmission of 90%. This 30% can be reduced to 2% if you follow these steps. Every woman should be started on ART, and once she is started on ART, the incidence, the transmission is reduced. Do we need to do LSCS in all HIV patients? No. LSCS is done only for obstetric indications. HIV may LSCS is not done. What about cord clamping? It should be a delayed cord clamping or an early cord clamping. It should be delayed. HIV is not an indication for early cord clamping. What about breastfeeding? Breastfeeding is allowed in HIV. Exclusive breastfeeding. Then viral load. One thing that is done in pregnancy is a viral load assessment at 32 to 34. Why are we doing this? Treatment we are giving to everyone. Why are we doing viral load at 32 to 34? We want to see what I should give to the infant. Infant is also giving antiviral after birth. If viral load is low at 32 to 34, I will give either nevirapine or zidovudine, anyone, till 6 weeks. But if the viral load is high, I have to give both, nevirapine and zidovudine both. This is according to NACO. So remember, if viral load, why was I doing viral load? To see what I have to give to the newborn baby. So if viral load is high, I will give 2 syrups. If viral load is low, I'll give only 1